Thanks, Rahul, for this opportunity to talk to a multidisciplinary audience. So I'm Dr. Rajiv Raman. I'm a retinal surgeon, a medical specialist, and I understand people here they don't have much medical background. So I thought I will teach you like a person who doesn't know anything about retina, anything about diabetes to start with, and then take it forward that how deep learning AI algorithms have paved way in diabetic retinopathy. Which one? So this is a small video which shows that what retina is when we look inside the eye from the pupil and try to see what is in the back part of the eye. This is a normal eye. You see a white color structure called as optic nerve head. You see the central part, that is the fovea, macula, and you see these blood vessels. So retina becomes one of the most important organ in the body or any part, tissue, where the blood vessel, the circulation can be visualized directly. You don't need any angiogram. You do angiogram for diagnosing certain disease, but that's the only part where circulation can be seen. This is okay, 1 minute. This is the patient with, I don't know why it is moving. Can I go through this? Here it is not. There's a delay. So this is a patient who has diabetic retinopathy. The same thing we try to look inside. If you remember the first picture, what you saw inside were those blood vessels, the central part, the disc. Here you see certain red color lesions, certain yellow color lesions, white color lesions. And this is a patient having diabetic retinopathy. So the moment you see these images, you'll say, yes, this is something which AI can definitely detect because the image has visible features. So I'll try to cover something about what is diabetic retinopathy. We'll try to identify some problems, how we can try to solve it, and how AI is playing a role in screening, diagnosis of the disease, and in the treatment. So diabetes is epidemic in India, and I'm sure my next speaker, my guru, Dr. Mohan, will delve in detail about it. I'll just, because that background is required, and this was the status of diabetes. So we have something called as the International Diabetes Federation, and 21, it said that 1 in 10 has diabetes. They predict that in 2030, it would be 1 in 9. And in 2045, 1 in 8 person will have diabetes. So it's an important problem. And what is worrying is that there is a lag between this and this. What is worrying is that, again, there is some problem, mismatch between both. Okay. Yeah. I say, yeah, this. On your system, you're seeing it correct? Let's start from now. So the problem is that 1 in 2 people even don't know. So I'm not seeing that. Yeah. So it's not the problem alone of these numbers, but another big issue is that 1 in 2 people don't know that they have diabetes. So diabetes definitely is a big problem. And this is the list of 10 countries. I think the countries have not yet come, but this is the list of 10 countries with maximum number of people with diabetes. Yeah, I think we'll connect it there. And it's almost half of the people globally, if you see China, India, and US combined, nearly half of the people with diabetes reside. So diabetes is a global epidemic, and it becomes very important as far as India is concerned. You're connected there? Yeah. This is what Dr. Mohan has described, that we have something called as the Asian Indian diabetes phenotype. It's not showing up there. Yeah. No. Lose connection. It comes there and goes. You have a HDMI port? You have a HDMI port?
Yeah, this is HDMI.
Directly put here. I have a HDMI port. This side only. This side. Yeah, I think it should stabilize now. So this is the front.
Yes.
Yeah. This one. This is front and this is back. Yeah. So he did describe, Dr. Mohan has described that there is a Asian Indian diabetes phenotype. So our diabetics are not as what we see in people in the Western population. We have lean diabetics who have more body fat, they have more central obesity, and there are many characteristics. I'm sure Dr. Mohan will explain this in a little more detail. He has also described some new subgroups in diabetes. The Zoom is not working.
Updated.
It's updated actually. Yeah, and I think again, I will just skip that, but there are different phenotype of diabetes which we see in India, and the microvascular complications seems to be a bit different among these groups. So we have a severely insulin deficient diabetic. I'm not going in detail. Another one having an insulin resistant obese diabetic. They combine insulin resistant and deficient diabetes, and the most common one, the mild age-related diabetes. Couple of them have more microvascular complications. So diabetes over period of time affects microcirculation in eyes, in kidneys, in nerves, causing various types of microangiopathies. Again, it is an important problem, and there has been this ICMR INDIAB study. This is a little older data, but when this was published, we had 77 million. Today, we have 101 million, the newer publication which has come. So we have 101 million people with diabetes. There are definitely urban-rural differences. The low socioeconomic versus high socioeconomic group. There's high prevalence now in Tamil Nadu, Kerala, and recently it's the Goa and Puducherry which is having more prevalence of diabetes. One thing which again came out was that there is a socio-economic diabetes epidemiological transition which is happening, meaning that in economically developed states, if you look at urban and rural difference is going. So even the urban area, we have more diabetes in lower socioeconomic status group. And in our rural areas, there is more diabetes in higher socioeconomic. Previously, we all believed that diabetes is a problem of higher socioeconomic status, but that divide is going. And in less developed states like the urban area, the prevalence is more still in the higher socioeconomic status. Now, coming to diabetic retinopathy in India. So diabetes, when it affects the back part of the eye, the retina, it causes changes called as diabetic retinopathy. This is one of our recent study which got published looking at diabetic retinopathy across 20 sites in India. The prevalence, overall prevalence of diabetic retinopathy is about 12% in people more than 40 years. What is alarming is that a couple of years back when Dr. Menon published his cure study, we had the SN Dreams. There was a divide, the urban-rural divide was there. But if we look today, nearly the prevalence of diabetic retinopathy seems to be similar. The same trend which we have seen with diabetes is also seen with diabetic retinopathy. The people in a higher ETL and lower socioeconomic status having more diabetic retinopathy as compared to the others. So what we learned lesson from this study was that one which is really striking is that the prevalence of vision threatening. So diabetic retinopathy can be in various stages, and at some stage, if we don't treat them, they can become blind, legally blind. And that prevalence is too high, that is 4% weighted prevalence, and that translates to nearly 3 million sight-threatening disease today in India, if we extrapolate it. We also found that there is this heterogeneity. They are not equally distributed across the country. That means we need to probably prioritize the diabetic retinopathy pathways in various states, especially the states with higher ETL and SDI needs to be more geared for diabetic retinopathy screening. We also found that in general, it is increasing with age, the prevalence of diabetic retinopathy, irrespective of urban and rural. So it's not like do only urban areas and leave the rural. So that's again a learning lesson. We need to have a systematic screening program. And again, the prevalence of vision-threatening retinopathy seems to be more in people who are already having known diabetes versus those whom we have diagnosed fresh as diabetes. So that again shows that more screening efforts should be done to people who are already knowing that they have diabetes. Urban-rural difference is negligible, so we need more people in the rural India. So that's about the problem statement. So we know that diabetes is important. It's a global pandemic type of thing. Diabetic retinopathy is important in India. No rural-urban difference, especially targeting people more than 40 years with known diabetes who are already knowing is something we should look at. Now, how this screening is done. So this is the All India Ophthalmological Society guidelines, which are published, and they tell about all the things which are required for screening diabetic retinopathy. And why it needs to be done, people know about diabetes, but diabetic retinopathy, only about a third knew in this study that there is something called as diabetic retinopathy. The worst part is, if you look at, there's no Hindi translation. So you have Madhumeh in Hindi, you have variety of languages, but if you talk about diabetic retinopathy, even that word is not there. So people don't know what is diabetic retinopathy. Again, this was a work which was done by Elizabeth Trust Foundation, and they found that 45% of the patients with diabetic retinopathy attending an eye unit, they had already lost vision when the condition was diagnosed. So that means that we are doing too little and much more has to be done in our country. So diabetes is a public health problem. There are socio-demographic differences. There's need for screening retinopathy. The awareness is really, really poor, and there's no systematic screening program for diabetic retinopathy. So how the screening is done, basically we target people with diabetes, how to identify them. You can have patients who are visiting an eye doctor or a physician or community screening, the NCD registers. good way would be to look at pharmacy shops to create awareness and labs. These are the places where a person with diabetes usually visits, and it's good idea to identify them for screening. What should be the screening interval? So this was the longitudinal study which we had done looking at incidence of diabetic retinopathy, and the 4-year incidence is about 9%. So at present, the guideline is that yearly checkup of all diabetes should be done. Now that means 101 million diabetes should have a retina checkup every year once, which is really very difficult. We'll come to that. And that's what is currently practiced. So there is definitely a need for a pre-screening strategy, because if you look at 101 million people with diabetes taking retinal image, we don't have so many cameras. Even if you take a average retinal camera, the cost is about 3 to 4 lakhs, next to impossible. So definitely there is need for something which should be done before screening, and those who are at risk, a retinal photograph can be taken. This was one of the work which we had done with a group in Iceland. We tried assessing the risk of diabetic retinopathy, creating a mathematical modeling based on the various risk factors, and it gives reasonable good accuracy. So this can be a one approach, that we do a pre-screening risk factor thing, find out if that person has a risk of DR, and based on that recommend whether he needs an annual screening or a biannual screening. That could be one of the things. The similar approach, we also, this was a work, all the population-based studies we tried looking at and trying to find out, can we do a targeted diabetic retinopathy screening based on the risk factors? And we did find those who are hypertensive, longer duration. If we use them, we can do a more efficient, more targeted screening rather than looking at all the people with diabetes. This was another work which we tried looking at a blood-based biomarker. Can we probably use a blood-based biomarker to detect vision-threatening retinopathy? This was done parallelly in India and in UK at Moorfields Eye Institute. So we looked into 16 circulatory biomarkers and tried looking at which are the best ones. Can we do a blood test and see whether a person has retinopathy? And there were certain things which were common both in UK and India, and cystatin C seems to be one of the biomarker. Recently, Dr. Mohan and group and Giridhar Eye Institute again validated it, and they also found the same results. So if you combine the age, the duration of diabetes, the HbA1c, cystatin C, you can reasonably well detect sight-threatening retinopathy. The current screening models in India, they are either an outreach camp or a opportunistic diabetic retinopathy screening. There are also mobile van approaches people are using. And the detection can be done community-based at the primary health center using these retinal cameras, or by ophthalmologists looking at the retina. The guidelines also talk about who should take a photograph. It talks about the variety of cameras, and for screening, minimum 6 megapixel resolution camera is reasonable enough to diagnose diabetic retinopathy. Many of you who are a little bit familiar just see this image and how many fields. So if you increase the number of fields, the chances of picking up diabetic retinopathy becomes more. However, American Academy has given a thing that 45 degrees central fovea, the macula-based image, is sufficient for a diabetic retinopathy screening. Recently, more work has been done on wide field screening. So sometimes you see these retinal images, which are 200-degree field of view. And these definitely are important. And now the definition of diabetic retinopathy also seems to be changing a bit. We are more looking at predominantly central versus predominantly peripheral lesions. And Jocelyn Group has very well shown that those who have these peripheral lesions, they have more chances of developing sight-threatening disease. They have 4 times more risk of developing proliferative diabetic retinopathy. Again, whether to dilate or not to dilate, because you're looking at a screening program where a drop is put, and after dilatation, I'm sure some of you who have undergone a retina evaluation, for some time the vision is blurred. So we have a lot of these non-mydriatic cameras. The problem is that nearly 30% of these images are non-gradable. You dilate it, it becomes good. So there are a variety of techniques like targeted mydriasis, or you do a staged mydriasis to screen retinopathy. Coming to, so we started with screening. We spoke about diabetes, then I spoke about what is retinopathy, how the screening happens, why screening is important. Now let's look into what are the various clinical phenotypes. So that is again very good. Long back, probably in 70s, the good epidemiological studies were done and which established a uniform classification for diabetic retinopathy. Now that is important because you have image and you have a very good system to classify the disease, which is universally followed globally. It lends itself for creating AI algorithms. So there are stages like, I'll not go in detail, but the ones which are green are the ones which don't need any treatment, and the lower ones, they need an intervention in the form of laser or injection or a surgery. Recently, a lot of work has been done on multimodal imaging, and that's something which is in our clinical practice today. The purpose of sharing this information are because as engineers, when you are trying to develop these algorithms, now people talk about multimodal imaging. It's not only a retinal image, but a variety of other things which I'll be sharing. So we have color fundus photograph, ultra wide field, autofluorescence, fundus fluorescein angiogram, OCT, optical coherence tomography, and now more recently we have OCT angiogram. Though I'm telling recently, but those who are practicing retina in India, 80 to 90% have all these tools. So it is something a clinician always uses. They use it to diagnose retinopathy. It can help in prognosticating a case. The disease outcome in cases of diabetic macular edema and proliferative disease also helps in monitoring the disease. Color fundus, I've already spoken. The more, the better. The bigger images are better. Exactly what I shown. It helps in grading retinopathy, and now we have PPL in diabetic retinopathy. Autofluorescence is basically you are showing a specific wavelength of light to the retina, and what is reflected is captured, and it gives some idea about inflammatory component in diabetic macular edema. Fundus fluorescein angiogram at one time was a very important diagnostic utility, but gradually it has reduced. Still, we tend to do a baseline fundus fluorescein angiogram. It gives the idea how the circulation is. It's more of a functional test to know whether the retina is perfused properly or not. OCT is our workhorse. Without that, managing diabetic retinopathy is next to impossible. Optical coherence tomography has multiple markers, now has been described. These are the biomarkers, which can tell us something about functional outcome of the disease. There's something called as drill. I'm just giving these terms because they are all useful when you think of developing any algorithm. So drill is something when so basically OCT is a cross section of the retina. And if the inner layers get smudged, you're not able to make out the inner retinal layers, that's called as drill. And it's very strongly correlated with a poor vision, even after the treatment. So person who is having drill, you give anti-VEGFs, the response, the edema will reduce. Anti-VEGFs are vascular and endothelial growth factor, anti-VEGFs, and it reduces the swelling. However, the visual outcome will be poor. We have, again, OCTA, it is correlating with ischemia. So we know that this patients who have drill, the blood circulation to the central part is poor. We have markers like the outer layer. Not sure whether you will understand this, if I can. So there are discontinuity in the parallel lines, which you see in the lower one. You have minimum disruption, you have patchy disruption, and you have a very severe disruption, again correlating with the visual gain a person will get. There are certain bridging processes. So if you have these bridging processes, they are basically Mueller cells of the retina. And if these processes are not there, the visual prognosis is poor. You have the cysts, these dark spaces which are there in the OCT, and the location of those cysts again determines the success. So these markers today for a clinician are very important because it gives the patient a realistic expectation, because you imagine these patients are getting injections worth of nearly 35,000, 5-6 injections, and after that vision doesn't improve, they need to know. As an AI scientist or data scientist, you must be aware, because these things people are now sharing algorithms which can detect these biomarkers with a reasonable accuracy. There are even markers to suggest whether the swelling will reduce. I'll not go much in detail, but some of them are inflammatory markers. So diabetic macular edema, one of the sight-threatening conditions due to diabetes, either there's an angiogenic pathway where VEGF mediated, or it's an inflammatory pathway. And there are many of these biomarkers which suggest that there is more of inflammation, like hyperreflective dots is one of them. Another is a neurosensory detachment. I'll just skip these things. So there are markers which can tell us whether steroids will work better or anti-VEGF, which is a treatment. OCTA is a new tool which all of us are still exploring, and that does give us idea about progression. We can know, even without injecting a dye, we can know how the retinal condition is, how the vasculature is. And what data scientists get is the huge data coming out of these multimodal images. How we manage diabetic retinopathy, it's definitely control of systemic factors. In diabetic macular edema, when it is involving the center part of the retina, they need injections. If it is not in the center, they need laser. In proliferative, where there is proliferation of new vessels, the treatment is laser. And in advanced stages, when it pulls the retina, it's a vitreous surgery. That's an auto check nitrous surgery it became. So that's all about diabetic retinopathy and diabetes. Now, the problems, what are the problems? So as I told you, how to screen 105 million people with diabetes yearly. Can we automate the screening process? Can we ensure a good systemic control? Can we predict progression of disease? Can we predict the treatment response? As I told you, these injections are costly, and can we say that whether this person will respond or not respond? How we can improve the compliance of treatment, because they need every monthly visit? And can we screen other complication of diabetes using these retinal images? And there came the role of AI in diabetic retinopathy care. So I'm sure all of you now know that basically AI is used in medicine for two tasks, either a classification task where you try to diagnose a disease, and in diabetic retinopathy, either a presence or absence of retinopathy, or you classify in those various stages with no, mild, moderate, or a prediction task, predict the outcome of a disease, whether the treatment will be effective, how much the thickness will reduce, those type of things. And predicting is disease from features which we not routinely use as a clinician. Can AI tools help us? So this was some of the work which we have done as far as classification tasks are concerned. Appears to be a low-hanging fruit. That's why a lot of publications, a lot of work is happening in this domain. Whether there is presence or absence of diabetic retinopathy, can we grade retinopathy? Can we classify whether the center of the macula is involved in macular edema? So what do the diabetic retinopathy screening guidelines tell about AI? And it was in 2020, American Diabetic Association, they included AI for diabetic retinopathy screening. And they said that if it's a FDA approved thing, it can be used as an alternative to a traditional screening approach. They went ahead telling that the results of these eye examinations should be transmitted to a healthcare professional. They also went ahead telling when not to use AI. If a person already is having diabetic retinopathy, it needs an in-person evaluation. AI screening should not be done. if he has already a prior retinopathy treatment, or if there are symptoms of visual impairment, these are the people who you should not do only a AI screening. In-person evaluation by ophthalmologist is needed. Even the All India Association AIOS guideline includes now AI for diabetic retinopathy screening. The big question is, are these algorithms accurate? And this was our first paper, Arvind and Shankanetrale, we worked with Google, and this was published way back in 2016. This was the first publication which spoke about using deep learning for diabetic retinopathy diagnosis. Happy to share that it was judged as one of the top 10 articles of the decade by JAMA, very high citations. And after that, there has been series of work which has been done on diabetic retinopathy, and accuracies of all of them seems to be reasonably good. So what to look for? Because now many of them are even commercially available. So what to look for when you try to select an algorithm? One is definitely number of images they have used in the training set. And more important is how the ground truth was ascertained. Because the machine, the AI algorithm will learn whatever it has been taught. So if it is, the ground truth is a very sound way, because there's a lot of discrepancies even among the ophthalmologists. So in the JAMA paper, we had 50 ophthalmologists, board certified US ophthalmologists, and they graded, and majority grade was taken as the ground truth. There are ways where you have 2 graders and then you have an education or an expert grader, or now in another study which we are doing with Dr. Mohan's group, where we are having 2 graders, and then if there is a discrepancy, they sit across the table and come out with one single final grade. So multiple ways the ground truth is ascertained. So whenever you are looking for algorithm, try to see these parameters, whether the algorithm was trained on a dilated image or a non-mydriatic image, because many of these, when they are trained, they take the best images, and when we use it in our real life, the image quality is not that great. Whether it was trained using a single image or a multiple image. Basically, you want to select algorithm depending on the circumstances of intended screening. So if you are planning to screen using a single 45-degree, one photograph, try to use the algorithms which have been developed based on that. We also tried looking at, is it camera dependent? So this was a work which we had done in Thailand. So Thailand, diabetic retinopathy screening is a part of their national health targets, and they have nearly 600 cameras across the country. And we tried using the ARDA, the Google AI, and tried looking at, there is influence of camera. And what we found that if the image is gradable, the performance of AI algorithm seems to be similar, though the rate of ungradability changes with the quality of the camera, but once the image is gradable, AI performs equally well. Can we do something to improve the AI algorithms for diabetic retinopathy screening? And we have, this is a couple of work which we have done trying to find out, can we know, because as I showed you, with some of these cameras, the non-gradability is as high as 30%. So we have created algorithms which can say this image is non-gradable. So it can give a prompt to the photographer to retake the images so that we can get less of these non-gradable images. How we can implement these in day-to-day practice? So there are a couple of ways. Can be a fully automatic way, like physician clinic who has a very poor knowledge on grading diabetic retinopathy. The images are uploaded and the AI gives a diagnosis and he refers. Or how we use at Shankanetrale, because we are 100 ophthalmologists. So where this can add as a value, we are only 19 retina trained. Others are anterior segment who do only cataract surgeries. So there we use it more as an assistive tool. We give so there's a small video which shows that how we have integrated it with our electronic medical records. So the patient goes to optometrist, a consent is taken, and once the consent is taken, the images are initially taken and these images are uploaded. The optometrist also has a chance to write whether person has cataract or whether the images are dilated for retinal image or a non-dilated image. And then he visits the ophthalmologist. He has a chance to look at the images. He grades the images for the severity of retinopathy. And then he says, I want to see the AI results. And using those, he can augment his decision. He can again relook. If suppose he has written it's a moderate, which doesn't need treatment, and AI said that it is PDR, proliferative disease, he can zoom in and see again, is he missing or anything he can add. So we at Shankar Nethralaya have been using it more like an assistive tool rather than a fully automatic device. What is the acceptance of AI among ophthalmologists? And this was again a global study which was across 70 countries. We had done about more than 1,170 ophthalmologists. And definitely the acceptance seems to be good. People want to use AI in their diabetic retinopathy care. Only barrier they feel is the medical liability from errors is something which is a concern as far as ophthalmologist is concerned. We have also tried using AI in multiple predictive tasks in diabetic retinopathy. Can we detect from a retinal image edema, which is from OCT? So can we detect OCT-based edema from a fundus image? Can we predict presence of retinopathy from pupillary dynamics and so on? So this was again a work which we had done with Google. Traditionally, macular edema is this yellow spots in the retina. If they are in the center part, the typical approach is that we train the model using these images, whether DME is present or not. What we did was a bit different. We used the OCT data, and from the OCT thing, we labeled it on the retinal photograph and then trained the algorithm. Can it detect the center involving DME, and validated in multiple countries? I'll not go in technical details, but this is what is the OCT macular edema and how it was defined in the study. And these are the results from the Indian data set. Reasonably good. I'll show some examples. So the top image, you can see those yellow deposits. Now this is a patient, if clinician sees, he will say this person has center involving DME. You do a OCT, actually there is no center involving DME. And the algorithm also seeing this image told that this was negative for CIDME. On the other hand, more interesting is the lower image, which looks totally featureless. I don't see any features of diabetic retinopathy, but on OCT, you see this central swelling, and the deep learning algorithm said that this person has center involving DME. I think this is one. Another work which we had done was trying to look at from pupillary dynamics, can we predict presence of diabetic retinopathy? And actually this was a work which we had published a couple of years back in scientific reports, where we looked into the various pupillary dynamics like the baseline pupillary diameter, a reaction to a flashlight, the hippus, the contractions which you see in the pupil. And we showed that they correlate well with various stages of diabetic retinopathy. And we used the same data to create a AI algorithm. And this is the initial result. Seems to be good. However, more work is definitely needed. This was a work which we had done on the with BITS Pilani. Exactly what last talk we heard. It's not only diagnosing disease. Can we predict the chance of having diabetic retinopathy from from the risk factors? And we use the same data, the data across all the population-based studies. Very recently, this was published where we ranked these risk factors and created an algorithm which could identify the presence or absence of diabetic retinopathy. I'll not go in the technical details, but these are the results. Without a retinal photograph, just by risk factors, can we detect retinopathy? Predicting a response to treatment. As I told you, the treatment is in the form of injections. Whether the edema, the swelling will reduce or not. This was one of the review which we had done. And then we tried two approaches to look into these predictions. One was, can we predict OCT, the thickness after an anti-VEGF injection? And this was based on patient-related data and OCT images. And a more physiological, we wanted to look at inflammatory markers. and whether that can predict whether the edema will reduce or not. This was the work with Zeiss, and we have trained an algorithm where we can put all the factors, patient-related factors like vision, previous number of injections, days after injections, and we use the OCT data. And based on that, it can reasonably well predict whether the edema will resolve, what would be the post-injection thickness which will happen. As I told you, this is more physiological approach we followed. There are inflammatory markers, which I had told initially. And these markers, we thought that can be learned from pure inflammatory. So there is another macular edema called as uveitic macular edema, where there is no role of angiogenic factors. So we used these images to train an algorithm to detect inflammatory markers and then use that on diabetic macular edema to see that how much markers are due to inflammation, and then try to look at, can we classify the inflammatory score and predict whether a person will respond to an injection or not. So for this, we had these 4 data sets: the uveitic, diabetic macular edema, responder and non-responder. And we had the grading platform. And I'll not go in detail, but we found what is called as these biomarker severity scores. And then finally had a thresholding to divide them into responder and a non-responder. These are the performance of this algorithm. This is a small video which shows how exactly we use it in our clinic. We can put single B scan or a stack of B scan, and it starts giving all the inflammatory markers one by one, and finally comes out with the overall inflammatory score and predicts whether it would be a anti-VEGF responder or a poor responder. So another work where one of the things, can we predict other microangiopathies from retinal image? This was a work which we did with Cambridge consultants. We had published it before that there are no discernible structural changes which happen in the retina, but there are functional changes which definitely happen in the diabetic neuropathy patients in the retina in terms of changes in retinal sensitivity. So we thought that can we use the same data set and try to see, can we detect neuropathy? And this was a blog by a Cambridge consultant in 21. This was from our SN Dreams population-based study. We had these training and testing data sets. This was the neural network. And they used various combinations. They trained the model on overall data set where it could perform pretty well. However, we found that those who had diabetic retinopathy, definitely the performance was better in detecting neuropathy. We also trained it on only diabetic retinopathy. Algorithm doesn't seem to work that well. However, when we trained it on normals without retinopathy, we got the best performance. And these are the 5-fold cross-validation results to detect neuropathy. Now that becomes important because this was first time we showed that retinal images can be used to detect diabetic neuropathy, and neuropathy is an important problem. We have nearly 100,000 people requiring lower limb amputation yearly. And if we can do both neuropathy and retinopathy screening at one time, that would be definitely an important contribution. I'll conclude the talk with some of the studies which we are recently completed, trying to use GPT for diabetic retinopathy. So one of the things which, as a clinician, I immediately thought that patients will start using it. People are already using, and they will get a lot of information. And how reliable is this information to the patient? If a person is we have advised him to get an injection, he'll ask GPT questions and the GPT will give their answers. How reliable it is? Can we use GPT alone as a risk factor engine to detect diabetic retinopathy? Can we use image, what we have done earlier, and add a GPT again, which can prompt the management of diabetic retinopathy too? And can we use it for a smart search? So this was the first study, how reliable is the information? And we created questions which were related to treatment. What a patient will ask if he has been advised laser, he has been advised injections. And we had 3 experts. One of them is from MV Diabetes. We had one international expert and one from Shankanetralaya. We wanted to know that what would be the agreement between these experts for a standard answer, which is created from literature search versus the ChatGPT. So I'll not go into much detail, but seems to work well. So the inter-expert agreement of the literature-based answers are still little variable, and these are the appropriateness. So we looked into 2 things, appropriateness and correctness of ChatGPT response. As far as appropriateness on a scale to 0 to 5, these are the various results for all the 20 answers. Overall agreement seems to be pretty good. And this is for the completeness of answer. Again, if across those 20 questions, the completeness also seems to fare pretty well, about 87%. So it can be a reliable source for exploring answers related to diabetic retinopathy for our patients. It's both appropriate and complete. We also tried using it to determine, can we make it as a risk factor engine? So we had multiple risk factors and we tried feeding these risk factors. It can be a pre-screening tool. And we tried looking at the agreement for the clinical diagnosis. Doesn't seem to work that well. However, when we added one more parameter, the central thickness of the retina, the performance of the algorithm, I'm not going in detail how we did it, but it improved. It has a potential to be used as a risk factor-based DR detection system. It's reliable, it is sensitive. And more recently, in our DBT study, we are trying to use, can we use the image-based and GPT combined so that the image gives the diagnosis and GPT gives the management? And this is the flow chart. It's been, so initially we did it on a public data set called as Macedor. First time somebody has annotated all these lesions in the Macedor data set. And after doing that, we tend to look at, can GPT provide the grade and the possible treatment options? So that obviates the need that will give to the patient the thing whether it needs treatment or not. Okay, so I think I'll just skip this. Definitely for efficient searching, it is needed. So managing retinopathy in 2023, possible implications, definitely AI has a role to detect sight-threatening retinopathy. It can even detect the OCT-related CIDME, center involving DME from a retinal image, and classify it as whether it is center involving or not, because treatment will change, can predict the treatment response. It can also we can look into screening other microangiopathies using retinal images. Thank you. Any questions? I'll be happy to. This is my team. I'd like to thank my team for all the work.
Thank you, Dr. Raman. Yeah, I see somebody has a mic already. You have a question?
Nice talk. So since we know that there's a strong correlation of gut microbiota with diabetes, so I was thinking, it would be good to include microbiome study in the current machine learning models so that there can be early detection of the disease, so that the patient can make dietary modifications and be healthy again.
I agree with you. And we had recently published gut microbiome data in diabetic retinopathy too. There is definitely no correlation, especially with diabetic macular edema, the inflammatory pathway through the gut. So there is a role. However, there are no clinical trials to really change. We don't have trials that changing gut microbiome can change retinopathy. We really don't have that evidence at all. We do know today that there is a link between gut microbiome and retinopathy. But how it will really impact the disease is something which we don't know. So it is a little premature to add it in a routine care. However, as you are rightly telling, at some stage or the other, it will be a part of our DR care.
Yes.
Yeah, so my question is more about you try to predict the treatment risk, like how the patient will respond to treatment, and you talked about disease progression, like this is correlated to disease progression. So it's more of a biological question, wherein do you see that diabetic retinopathy as a heterogeneous disease, or it's just a disease progression because of which inflammatory marker goes up and down?
It is definitely heterogeneous. That's the reason you need to look into not only one, but they are reflected today in our clinical care. We do use these OCT biomarkers to predict. No, we don't have a very long-term studies yet, but we know that certain biomarkers are associated with a poor response. There are certain biomarkers which are associated with a good response. There are biomarkers which predict the visual gain which can happen. So using the current knowledge which is already there, creating a AI algorithm, these may not, and as far as the prediction for developing sight-threatening retinopathy, these are based on risk factors. Now, it will change. I don't see those algorithms to really, it will different. So if I use that retina risk algorithm and tell a patient that you have a chance of 40% chance of developing sight-threatening in 2 years, but I also tell them that you work on these risk factors, reduce it. Probably 6 months later, if we again do this test, the risk will reduce. So it's a dynamic process. It's not like what we have told today will definitely be true. If we change, because it is not a genetic disease, it is it's a lifestyle disease. There are multiple other factors which play a role. But what I see is that the moment we say that you have a high risk, definitely the other things will get controlled better.
Dr. Mohan has a comment on the previous question.
This is regarding the gut microbiome question. So what we did was we did an Indo-Danish project. So we had people with normal glucose tolerance, no diabetes, we had pre-diabetes and diabetes in India, and the same thing in Denmark. So the idea was that we will be able to find a gut microbiome which is specific to diabetes, and then, as you said, include it in the model. So it turned out that Indians and Danes have completely different gut microbiome. That means you look at the gut microbiome, you can say this is an Indian and that's a Dane. Of course, you can do it by other methods as well, but the gut microbiome, there's no overlap at all. The completely different. But within the Danes, if you looked at normal pre-diabetes and diabetes, disappointingly, there were no differences. And again, within the Indians, if you looked at normals, pre-diabetes and diabetes, again, there were no differences. The other complication was the moment you start treatment, the gut microbiome changes because metformin changes it, acarbose changes it, many other drugs change it, your diet changes once you take. So it's not something which is fixed, unlike your genome, where once you do that, you know that you have a genetic risk and then you can use it for prediction. So gut microbiome changes so much and it's very difficult to do, very expensive to do. So it's still too early to introduce it into routine care. So that, I thought I'd just make that point. Thank you.
The other very complicated thing about gut microbiomes is that when we say it, we usually mean fecal microbiomes. But gut is a long thing. And so recently we just published a paper. We looked at duodenum. So from with PGI Chandigarh. And in pre-diabetics, the most striking finding was almost a log-fold higher bacterial content in the duodenum of people who had pre-diabetes compared to the ones without. So one dimension that we might be missing in India might be over-colonized guts in the upper gut, which would again link back to the sanitation issue I was bringing up over there, which might be potentially driving inflammation and diabetes. On a lighter note, you can imagine a person coming for eye treatment. Because when we did this study, he comes for a proliferative vision problem and we say that we need your stool sample. Gone. You can imagine how they will, because they can never think that this can also correlate.
Yes, and how will you get a duodenal sample routinely?
Yeah,
Anyway.
that becomes still.
Right. Okay, any more questions? Yes, back there.
I just like just a comment. I mean, the study which Rajiv talked about, the Google study which Shankar Netra did with our institute, Arvind. One particular interesting thing came up was that the AI model there was able to predict how much was it, 99%, the gender of the retina. So, in fact, I had remarked to Rajiv that is there something now like a male retina and a female retina? You know, so this is something for the life
Oh,
professors.
more interestingly, I've not covered those work, but
Yeah.
now more interestingly, people talk about retinal age. So like gender, it is able to predict very accurately the age, and that age doesn't match with the chronological age, exactly what was spoken before. And that difference of this age predicts mortality. A lot of work is happening in that domain too.
Very interesting.
Yeah, just to comment, last week we had an online talk by Dilraj Grewal, who also commented about how the retina ages and also is heterogeneous across people of the same age. So just using a retinal scan in his case to detect neuropathy is basically neurodegenerative diseases. That's his area of research, but it's complicated. More questions? Yeah.
Sir, so in one of your slide, you have shown the strength of AI model with the actual value using the correlation coefficient. If you go back to those slides.
Again, join, or I'll just show from here directly. I think these two.
Yeah. So here your objective or aim is to find the agreement between the predicted value from the AI model and the actual value, right?
Correct.
Since the correlation coefficients are means very much influenced with the outliers, so I feel you may look for another methods to calculate the strength of association like Bland, Altman, and yeah.
I think they have done, I've shared this is a little older site from
Okay.
guys, but the publication is just accepted. I think within a week you will see in diagnostics.
Okay.
So you will see that they have done what you have told, but this is from the
Yeah,
last.
because then you might get better strength instead of.
As a clinician, what I feel, what came out is that the results are better with more number of injections. So if a person already had
Okay.
2-3 injections, the predictions are much better as
Mhm.
compared to a treatment naive individual. That's what, as a clinician, we took out of that. But
Okay.
what you are told is absolutely correct.
Yeah, thank you, sir.
Thank you.
Yeah.
Yeah.
Please.
Hello. Do you see any variation or difference in the blood vessel networks between the two groups, the one who have diabetic retinopathy and normal retinal images?
Yeah, so there are a lot of work on fractals in diabetic retinopathy, and we have also published some of them. It seems the fractal doesn't change much in stages of retinopathy, but it does give idea about some systemic conditions. So Dr. Tin Wong from SERI, he was one of the first person to correlate these fractals with the cardiovascular parameters. So people use that more for systemic circulation, the arteriolar and venular changes. But for diabetic retinopathy in general, more for hypertensive. In diabetes, what we see is a venular dilatation as compared to the hypertensives where you have the constriction of arterioles. So that's as far as clinical, but it is not much required for stages of retinopathy, but for systemic, yes, fractals are important. We also describe the various ways of calculating fractals. One of the thesis student of Anna University of mine, it seems like there are 5-6 methods, and which one works for retinal image is something which we have described.
Questions? So it's past 1 o'clock. So let's thank Dr. Rajiv again for a very illuminating talk.